Today, our special guests are Jose Perez, father of three and fiancé of Christine Fields, who will share his personal story and advocacy work with us, and Dr. Candace McLean, the appointed director of nursing for maternal health over Suffolk County, New York State. I'm your host, Bria Anopise, and I'm joined by co-host Jessica Idobali, Director of Collaborative Programs at AWHONN. Jose, our team is sincerely sorry for your family's loss and saddened by how Christine's life ended. We know that discussing maternal mortality is a sensitive area, especially when it's your personal story. I'm going to turn the podcast over to Candace and Jessica now to discuss how you've redirected your pain and pivoted to advocacy work to voice your concerns about maternal care management in underserved communities. Thank you so much for being with us today.
Thank you, Jose, so much for your time and willingness to share this story with AWHONN. Please, briefly, tell us about who Christine was and share your experience leading up to the fateful event. I know you mentioned you all utilize midwifery services.
So Christine was a 30-year-old mom. Christine was a mother to three children. Christine had her first child in 2018. Christine had just enrolled in college at the time. Christine went on to having her second child in 2020, my daughter Nova. She was still in college working. She was about to be 30. In 2023, Christine turns 30 years old. She's pregnant with our third child, Anuel. On November 12th, 2023, we woke in, Christine's in having labor pains that day. We feel like she's ready. She's 30, like 39 weeks. She's ready to give birth. She's all the way. She feels she's ready. She already had two children prior, so she feels like she's ready. She's ready to go to the hospital. Christine says, "Hey, we ready." The day before that, we set everything up. We set everything up for the baby on November 11th. November 12th, we make our way to the hospital. On that day, as we get to the hospital, Christine is in labor pain. Christine asks us to see the medics. Doctors see her. They come in, they see her. They tell Christine she's like 2 centimeters. And they proceed to tell Christine to walk the corridor for hours because she's not ready for labor. They put us in a small hallway, make Christine walk back and forth. At that point, Christine's very uncomfortable because where they have her at, as she's in labor pains, and we decide to go to her mom's house. We leave the hospital, we go to her mom's house. We end up back at the hospital about 12 o'clock in the afternoon, same day. Christine is put in a room. Christine was administered morphine throughout her stay in the labor room. At that point, something goes wrong with the baby's heart rate. The baby's heart rate starts dropping about 10 something at about 11 o'clock at night, 11:30 at night, sometime around that time. Doctors come in the room and doctors are screaming on, is Christine needs a C-section. At this point, we confused. Christine wasn't planning on a C-section. Christine had a birth plan. Christine worked with midwifery services prior with our daughter. Christine was in contact with a midwife since our daughter was born in 2020. So we were looking forward to having the same midwife. Christine had called her that morning on the way to the hospital, but she was on a 24-hour shift and she could not see Christine that day. So when we arrived to the hospital, our whole staff was switched over to some other care of another midwife. We didn't get the same care and the same provided service that we had gotten before. From about 11:30 at night, Christine is rushed into an OR. As the doctors came in the room, telling Christine she needed a C-section. They came in there with security guards. As I'm trying to advocate for Christine, the doctors are just screaming at Christine. They're not trying to hear what I'm saying. They're not trying to hear what Christine is saying. They just telling Christine she needs a C-section. At that point, I'm talking to Christine. Doctors security's there. Security's intimidating because I feel like I can't advocate for Christine because I feel like if I say certain things, I'm going to be put out the hospital. telling the doctors Christine gets anxiety, Christine is crying. At no point Christina is giving them trouble, though. She's just crying, she's just worried. After that, Christina is rushed into an OR. Security keeps me out the OR, and about 11:50 at 11:55, I see my baby. My baby was born. After that, I go to the NIC unit with my baby, and I spend a few hours there with my baby. I make sure the baby's okay. I get some pictures of him to show Christine. When I come back to look for Christine, Christine's in the recovery room. About 2:30 in the morning, I find Christine in the recovery room. Christine's lips are looking gray, ashy. Her tongue is hanging out her mouth. She's just laying there looking very dehydrated, very discolored. I asked the nurse, could I give her some water? The nurse proceeds to say no because she just had a C-section. She offered some ice chips for Christine's lips. I go to prop Christine's head up to rub ice chips on her lips. At that moment, I noticed something was wrong with Christine. I noticed something was wrong with Christine just because by the way she looked and the way her head slumped to the side. And I told the nurse something's wrong with Christine. The nurse proceeds to start screaming, cause a cold blue. A few hours later after that, Christine was no longer with us.
Every time we hear this story, it's such a powerful story, and it brings such a deep insight. And we appreciate you sharing the insight because we're hearing consistent themes. You mentioned screaming, confusion, the prolonged shift, but most importantly, the inclusion of voice. Negative clinical outcomes have been commonly associated with us not having the ability to have voice. I'm going to ask you, and you did start to tap on it, how are the nursing team providing support to you or towards you during this moment in their care, their mannerisms during this traumatic moment?
There wasn't no mannerisms. I was never pulled to the side. I was never there was never no conversation of awareness of a C-section or why we had to go into the C-section and was there any other alternatives for Christine at that moment. It was just a lot of chaos in the room, a lot of confusion. Security's there, so it's intimidation. It's just, yeah, it was just, it didn't feel like a place that was under control. Like medical staff knew what they were doing. Like it wasn't like that. Definitely wasn't that way.
Jose, I want to thank you again for being so vulnerable and sharing your story with us. I know it's really hard. And to that effect, I want to just take a couple of minutes, or not even a minute, but 30 seconds to just take a deep breath and then just a little bit of silence out of respect for Christine and out of respect for everything that you've gone through before we start just asking a bunch of questions. As I think about your story, and this is the second time I've heard it, what keeps on going about my mind is what things could have gone different as far as nurses trying to educate you at that time. We're always striving to improve our education, and we are trying to do it with the balance of not scaring the patient. But when it's during the time and it's urgent, how would you have liked to be approached? What things do you think could have worked?
So I think the approach could have been very simple. Not coming there with security, first of all. Make it feel like it was a hostile situation, because there was never a hostile situation the whole time me and Christine were in the labor room. And we could have been approached differently. They could have came in there, hey, Mr. Perez, hey, Miss Christine, the baby's heart rate is dropping. X amount of time, is very dangerous for the baby. We have these options. This is option number one. This is option number two. If we take X amount of time, we wouldn't have these options, you know, make it, I didn't feel, at no point I felt like I could have asked any question. It was just C-section, C-section. So I didn't know if I had, me as a parent, I didn't know if I had 1 minute or no minutes to ask questions. They knowing and working in this medical field, I should have been approached differently. We should have been approached differently as a couple, me and Christine. Christine should have not been frantic. They should have not frantic Christine over a C-section. If you come in the room screaming about a C-section, I'm pretty sure any mother's gonna get nervous. Any mother's gonna start crying.
So I think, and I'm just gonna rephrase for a second. What I'm hearing from you is that because it was so chaotic, because people were more yelling and telling instead of informing and saying, Jose, the baby's heart rate is down. We need to have a stat C-section. We need to go. That moment is that you didn't feel like you had agency, like you didn't feel like you had a voice.
Correct.
Okay.
Correct.
I want to pivot to patients' rights real quick. What did you know prior to going to the hospital about patient rights and family rights and how to notify the higher ups when you didn't feel being heard?
Okay, so me and Christine know about birth plans. I know about the patient advocate at the hospital. I know about hospital directors. Sometimes you can ask to speak to the hospital director if you're not being, seen properly. We weren't feeling like that. That's not how we felt up to a C-section. Up till they came in the room. Maybe looking back, maybe Christine wasn't checked on as much as I think now she should have been checked on during that day. But that day I didn't feel like that. Like that day I wasn't feeling like that. She was in labor, we there, they didn't, like I say, not looking back now, they didn't come in and check on her as much as I think they should have, but that day I didn't feel like that. That day we didn't feel that leading up to the C-section, we didn't feel anything besides the time that we were asked to walk in the hallway, in the morning. So that was the only time we felt uncomfortable, but we didn't feel like we needed to make that a situation to where we needed to speak to a higher representative at the hospital because Christine ended up going home to her mom's house.
So I want to stay on the same theme of providing patient education before coming in. So do you think there would have been some valuable lessons before you reached the time to deliver, like prior to birth? Like, was there things that you knew about the risks of childbirth or about emergencies? Like, is there something that we could have done as a community of nurses to prepare patients and their families for what may or may not happen during the delivery process?
So going back, this is our third child, so I'm very familiar with birth. I'm very familiar with birth. We never had this. The only difference I could point out from the third birth to the two prior births that I was never prepared for, or was a bunch of doctors running in a room screaming. I was never prepared for that mentally, emotionally. That was a very difficult thing to process and to comprehend everything that was going on at that moment. My worry is Christine. My worry is okay wife, okay baby. I'm trying to bring both of them home. Baby and moms. That's my focus. And those are things that I think people need to be prepared on. C-sections are real. C-sections can happen. I'm not saying C-sections can't happen. Like there is times that women do need a C-section. I'm not saying C-sections shouldn't happen at all because sometimes they are needed. And like I said, it's something that I wasn't prepared for, and I don't think any father is prepared for. A group of doctors and nurses running in a room screaming about a C-section, and they never been in that situation. They never experienced that situation before.
Before I hand it over to Dr. McLean, ask the next question. Do you think it would have been helpful if you had that conversation with your midwife prior and it would go something like this, Jose and Christine, if things come to a place where there might be an emergency, you might see an influx of people coming in to try and hurry things to get to a point. Do you think that might have helped your situation if you knew that before, or help at least you understand what was going on if you had that before coming into the hospital?
Yes, so definitely if I was aware of how many people were running in the room, if I was aware that, they're gonna come with security because they think that patients might escalate a problem, if I was aware of those things, then I would have had a better understanding and a better feeling, and I would have been in a comfortable space, and I would have known, okay, this is bound to happen, so I have these questions prepared in case this happens.
Yes. Yes, sir. Thank you, Jose. I'm going to turn it over to Candace. Thank you.
Thank you.
Jose, the points that you bring are so important because providers out in the community need to hear how it comes off when people are enduring a traumatic event and also know, though we don't want this fateful event to happen, how do we navigate it with the family members to prevent post-traumatic distress? Maybe do we need to assign someone to the patient's family member to keep them updates during the event? So I appreciate you going into detail about the specifics, about your interactions with them, whether it was security, whether it was with the obstetricians or the nurses during that event. What were some community resources you felt were valuable to you during the immediate post event?
So in my situation, everybody's situation is different. My situation, the only support I got was community support, just from the community. The hospital in no way helped me. The social worker at the hospital, she made it very difficult for me to obtain my child. She held my child for 11 days at the hospital for no reason, just because she wanted to give my child to the grandmother. She was working against me. It was hard for me to obtain my child's birth certificate, my child's social security, because they didn't put in paperwork. They didn't do their part. So I didn't have, I wasn't, the only resources I had was community resources, which when I say community resources was people from my neighborhood that helped me, little, just people that start little organizations and stuff like that. But as far as the hospital reaching out, resources from the hospital, or as far as that I felt I should have been helped with, I was denied all those things. I didn't see any of that help.
I appreciate you sharing that, Jose, because that gives out insight to community based resources and organizations about some work they do, but also the hospital's component, as we tend to think about fetal demise, but there's lack of support for bereavement for actual fathers after. I know from social media messaging, you're motivated to advocate for safe birthing practices. You just did a wonderful talk out at the college in Brooklyn in honor of Christine. Through awareness or changes in healthcare policies, you're bringing light to that we need to do better safe birthing practices. Overall, what are some pertinent changes that you would like to see? What would you like to see differently?
Mannerism is one thing I would like to see. The way patients are just spoken to at the hospital, when it comes to a certain, like I said, to even just to my situation, not greeting families with a team of security, making the family feel uncomfortable, I'm working on policies. I'm working on a policy, just to have doctors evaluated. So things like that, if there's these laws in place where, doctors at some point, like if you cause a maternal death, someone steps in and evaluates you and to see if it's your performance or it was actually a mistake, you know, things, just small things like that, that could save someone's life, things that could change how patients are seen at the hospitals. I've been working with a lot of groups, other organizations, and I've definitely been out here speaking at a lot of rallies and a lot of places, helping other families. So, yeah, I'm definitely working on small changes as of right now. My biggest goal is, and that I'm working on, that I work on the hardest, is the Grieving Families Act. The Grieving Families Act hasn't been updated since 1846 in New York State, and Alabama are the only two states that do not have an updated Grieving Families Act, and it's very important. Yeah, these are the things I'm working on.
Before we turn it over to Jess, I want you to elaborate on the Grieving Families Act because, from my recollection, it only gives the families who survive of the person that they lost only 10% of their salary or so forth of their income. Can you just elaborate or clarify more to the audience about the Grieving Families Act and why it would be so valuable for that to be updated?
Okay. Yeah. So the Grieving Families Act in New York State and in Alabama, like I said, are the only two states that don't hold the updated Grieving Families Act. So in New York State, a lot of underserved communities, people have basically no value because they consider they have no value, so like in I'm just gonna point out my case. I'm just gonna use my case. In my case, when I brought a lawsuit against the hospital, um, the first thing I heard was Christine has no value. And I'm like, why Christine has no value? Christine was 30 years old. Christine just graduated college. She just got her bachelor's in criminal justice and science. Christine was working for a better future. Christine held a full-time job throughout 4 years of college. So I'm like, how Christine has no value? I was confused. And so when we say Christine loses her life, we filed a lawsuit. They tell me, well, the only ones that could be compensated are her children, her moms. Her moms can be compensated for pain and suffering or anguish. Because New York State doesn't allow that. And I think that's very unfair because Christine would have been here. Christine would have definitely been here. And she would have definitely made a future for her children.
Jose, we appreciate you sharing that insight, and that's why I'm even though I know it's very hard to speak on, it's so important that you get this message out because the Grieving Families Act needs to change, right? Because there's no value that you can place on the life of someone that has been lost. We need to have our voices heard, and that's why we need to really have this out there for legislators to hear to make that impactful change. Already, the traumatic loss of someone is already enough to deal with, but to hear that they're placed with a value really need to make an impactful change at that address. I'm going to turn it over to Jessica.
Jose, when you talk about the value of a person, you started saying Christine did this, Christine did that, and that made her valuable. I think regardless of what she did, she was just valuable. She just sounded like a beautiful and wonderful person. So I'm glad she made all those accomplishments, and I'm glad that she was just so fantastic. But value, everyone has value. And I think that your advocacy in this line of work is incredibly important. And I want to thank you. I didn't have an additional question, so I'm going to pass it on to Bria. I want to thank you again. And if you need any other resources, like Postpartum Support International, they have, I don't know if you have a support group that you're going to right now, but they have a father support group for fathers who have gone through traumatic events. We would be happy to share those resources with you. And I want to thank you again for being a guest on our show. Bria?
Yeah, Jose, we're grateful that you shared this life-changing experience that you're still living with us, because we know that it takes everybody involved in birth work to prevent maternal deaths. And so I want to let you know that your voice rings loud and we hear you. There will be nurses, midwives, social workers, other healthcare professionals, and legislators. They're going to be learning about you and Christine's story, and they're going to be making different decisions, especially in emergencies and in situations like the one you had where things don't go exactly as planned. We know based on the work that has happened over the last 10 to 15 years that staff training and healthcare policies will be updated and implemented so that other people and couples who come in and are having a baby don't have to go through the same thing that you all have already gone through. So we admire your strength and your advocacy. We know that you're in the midst of raising children, and you're also continuing to heal from this profound loss of Christine's life. And Jessica and Candace are right. Christine has value, period. And so we will continue to speak her name. For people who are listening to this podcast, thank you. You can go to awhon.org/podcast to read Jose and Dr. McLean's bios and utilize the resources they shared. You can watch and re-listen on YouTube and other streaming platforms. If you have a comment or question, from anything in this podcast, you can send it to podcast@awhon.org. And we ask that you share this with a friend so that they can learn about Christine and Jose's story. Thank you again for listening. Thank you so much, Jose and Dr. McLean, for being here with us. Thank you, Jessica. And everyone, be well and stay safe.
Thank you. Appreciate you.